Vaginal hysterectomy with PFR versus laparoscopic management of pelvic floor. We have two eminent experts ready to engage in a thought-provoking exchange. Please join me in welcoming Dr. V.P. Paili sir and Dr. Kurian Joseph sir to the stage.
Good evening. I know the attitude of all of you now. The earlier we finish, the better. So we will rush through that, Kurian. But is there any need for any debate on this? I know Kurian is such a famous vaginal surgeon. I am sure he will support that vaginal approach should be the one to tackle pelvic floor defects. So actually, for the sake of bringing out some of the points, maybe we would. Usually we say that prolapse is like a hernia, but gentle prolapse is not like the typical hernia. For example, we occasionally get things like this. See, the patient is made to strain and you can see two bulges there. The upper one, that's the usual that we see as a gentle prolapse. The lower one is actually typical like a hernia. Through a small defect in the near the apex of the vagina, that is the omentum and the fluid coming out. That we can say is something like a hernia, like an inguinal hernia. But usually, gentle prolapse is not the typical hernia. It is not something protruding through a narrow orifice and coming out like that. Is our concept, inguinal hernia, for example, isn't it? Here it is not like that. It is due to weakness of all the supports. That's the point we have to keep in mind. Prolapse, gentle prolapse is due to weakness of all the supports. We can have an isolated level 1 defect. We can have an elongation of the cervix coming, but they are not the common. The common gentle prolapse is due to weakness of all the supports. And this is the price we are paying for our upright posture, as I referred to earlier in my talk. One of the prices we pay is that, and to some extent, as a result of vaginal delivery also. That adds to the problem. The pelvic floor, as we think about, this is a classical textbook picture. There is the trough, the levator, with the coccygeus muscle added. That's the trough. That provides the basic support for all the structures. But that by itself is not what keeps the pelvic organs in its place. This famous suggestion by regarding the endopelvic fascia, its support, if that is cervix, posteriorly the uterosacral ligaments take it to the sacrum, anteriorly the arcus tendineus takes it to the symphysis pubis. So it is like, it has to be base, there is the levator, but above that, what keeps these organs in place is this fascia and the ligamentous supports. So, if that is the case, to put it further, if that is cervix, this is a pericervical support here, but from there to the side, to the ischial spine, to the pubic symphysis, and back towards the sacrum, it is an additional facial ligamentous support superior or cranial to the levator. That is what holds gentle organs in place. If they get damaged, you get the prolapse. So that's something basic. So when we talk about the pelvic floor, what is it that we are talking about? We are talking about the pericervical ring around that and the ligaments which will take it towards the sacrum and the ligament and the fascia which take it to the pubic symphysis anteriorly and to the sides. So this is what got weak and that is what has come down. Now, with all respects to our endoscopic surgeons, what do? If something has come out, you push it back and hold it at the wall, at the tip, and then pull it back to the sacrum. Use the presacral ligament or the 1 or 2 level the normal attachment of the wall to the vagina or the level 1? It is not. It is the uterosacral ligament which goes further down on the sacrum. Anyway, to access these areas, to cover that defect that has happened, we talk about the different compartment, the apical compartment and the anterior and the posterior. And for each one of these, we can approach them much easier from below. And that is vaginally. That is my point. Some examples of defects like this, or like this, or like this, with ulceration over there, or combined defect like that, or simpler one like this. How many of them will be easier to tackle laparoscopically from above is the question. Whereas, as all of you know, we can tackle all of them. Not only that, we can restore their original supports and anatomy, and the consequence of its coming out and the laxity also we can cover. In other words, earlier what we saw, that huge prolapse coming out, if you just pull up this wall to the vagina back, that alone is not. The whole vagina is roomy, introitus is so flabby, and that also needs attention. How do we do that? Vaginally. So all this is actually an 84-year-old cardiac patient, frequent hyponatremic convulsions, wall prolapse. This one, 78-year-old, these patients come for repair and they need help. And if you have to do a laparoscopic surgery for them, how many of the anesthetists will be willing to give the anesthesia for that? So my point is, this is a recurrent prolapse which I showed you earlier, so we will not wait. But this is one situation where I would also go laparoscopically. This is a nulliparous prolapse, basically elongation of the cervix, which I would tackle laparoscopically. What she needs is to give support to take that level 1 up, and excess vagina, excess cervix, you amputate. So I'm not saying no laparoscopy, but by and large, the prolapses should be tackled from below, vaginally. Hysterectomy, the way Jason has put it as hysterectomy with PFR. Hysterectomy is not the important part. It's the PFR, the pelvic floor repair part. It is the pelvic floor repair part which is better done vaginally rather than abdominally. That is my point. We can, very rarely only people rectify a levator tear that has happened, but we rectify the facial as well as the ligamentous ones and reconstruct the pericervical ring, and this is best done by the vaginal route. We use the ligaments for that. You know the sacrospinous ligament. We talked about it many times today, so we don't want to go further into it. And this is the way we can do it. I told you about the McCall's, where how we do it from one side to the other. You can use the uterosacral ligaments for that. And you can use the sacrospinous ligament. You can use the arcus tendinous fascia pelvis, how to access it from the vagina, I already told you. And with the dissection, if you keep the fascia with the vagina and bring back the fascia, that restores. Of course, once it is damaged, you cannot get back to the original, but at least it is much better done vaginally. That is my point. We may have to do surgeries for women in their very late ages, like 80s and 90s. And for all of them, to restore the anatomy at all levels, vaginal approach is the best. That is my contention. Thank you very much.
Thank you, Paili sir.
and thanks to my worthy opponent's lovely presentation. He's collected almost all the old women in Kerala and taken their pictures. Hands off. I'm not trying to fight against that. So all of you please read the topic carefully. Pelvic floor repair, vaginal hysterectomy with PFR versus lap management of the pelvic floor. The interesting gentleman who created the whole debate is missing. So I'm wondering if he was there, we could both. So I appreciate the courage of Professor Piley. This is called confidence. He can take any mass which comes out, push it up, stitch it, and he says it stays there. But I don't think it will stay there. It will all jump out. And that's the confidence with which I can tell you that. It's not very simple and straightforward. The first point, the topic of the debate I have to fight. Why remove the poor uterus? Because you can't repair well otherwise, vaginally? Anyway, he said he will do it even without removing the uterus. So this is a technically flawed debate. And that point, I think we have to drive home and make it definite that vaginal hysterectomy is not a component of pelvic floor repair. Because if you say that, I rest my case, my opponent would straight away lose. Let's go on further. Is there need to operate every prolapse? Many of those bulges which were there would have remained comfortably with that woman without creating any trouble, and she could have lived with it. Just because the vaginal surgeon is there, they have to repair it. Let's say it is a symptomatic mass, something causing trouble, then we can think in terms of doing it. Otherwise, no. Sir said about the sacrospinous fixation, anchor it. This was a technique which came up quite some time ago, in 1954, I think it's come up. Fix it one side, fix it the other side. Because they could fix it this side or that side, they said we are deflecting it this side and deflecting it that side. Because they couldn't fix it in the midline. There's something else in the midline. But what it does is just take a little bit of the vagina and anchor it to the apex. This is another wonderful repair. The Fothergill Manchester repair. This was the patient who developed stenosis after the repair. And you can see how beautiful the repair is. You can see the lips of the cervix, absolutely terrible. We tried to put a hysteroscope in, we found there is no cavity that we could enter into at all. Because in these procedures, it's the ability of the individual which matters so much. If they don't trim the edges, they don't close it properly, you're just going to have chaotic scenes like this, where nothing is seen, you can see nothing can be accessed, and the patient remained amenorrheic because we could not open it out. So let's just analyze the whole of vaginal. We've been watching from today a lot of vaginal repair. But what does it contain? It comprises dissecting out the layers of mucosa, fascia, mobilize the bladder, open the peritoneum, pick up some tissue and say that is a ligament. We really hope it is the ligament. Then excise the redundant tissue, bundle it up, close it and call it repair. You all agree with me or not? That's what's being done. If the existing tissue is weak and poor, then we need adjuvants. But sadly, we can't use anything. The mesh was used, marketed extensively, but was withdrawn and now it has been banned. So we can't use any support there. The only person who's using it is my worthy opponent, and he uses it very well, but even I don't have the courage to use it. So what alternatives do we have? We just have to depend on our luck that we have got some firm tissue, fixed it at the correct place. So why does vaginal surgery have so much success? Vaginal prolapse treatment has high failure rates, but patients still report an improved quality of life. And that is why all these vaginal surgeons are escaping. If you see the uterosacral ligament suspension, you take the sacrospinous fixation, we're talking of failure rates of anything between 70% to 61%, which is a very, very high failure rate. But only a few of the whole lot, only 12% of the uterosacral patients and 8% of the sacrospinous fixation patients were treated again as they had an improved quality of life. So that is again the thing. So this is possibly the reason why vaginal repair still survives. If you had taken your POPQ, you had taken any measuring device and checked the quality of this vaginal repair, you would have found that it's not there at all. That cystocele bulge will be there, that side bulge will be there, paravaginal bulge will be there, everything will be there. Now, when they anchor it vaginally, they just have one sacral spine. Whereas when we do it, we have all the points in the pelvis to use. Now, would you like to just anchor it at one point, or when you have so many places, anchor it firmly? And remember, all these are bony supports, as against just a ligamentary support. So this, again, is a big advantage, which possibly with the vaginal repair you could never achieve it. True, lap repair is comparatively junior. It's still not got very long studies. But some small studies like from 2012, that's just 10 years, they've had 66% success, and the remaining had symptoms and had to be treated. When we think of sacrohysterocorpopexy, we basically take a mesh, fix it onto the sacral promontory, and from the sacral promontory, bring the mesh down, and you can see you're opening it. You're seeing it well. It can be done by any of you. It need not be done by me. It doesn't require any big teaching. We open it, go right up to the posterior region of the cervix. At that point, here we open, mobilize the peritoneum anteriorly, make a window on the broad ligament, and then we take a mesh which is Y-shaped, take it around the cervix and anchor it. So this is the whole procedure of sacrocolpopexy. This can be supporting both anterior and posterior. I mean, it's too much to show otherwise. So we brought it across, fixed it anteriorly, then brought it back, closed the peritoneum. See, procedure is a nice, simple, clean procedure. We are supporting all the regions which the vaginal surgeon would use, and then we peritonize the whole structure, suturing it to the sacral promontory, keeps it anchored well to the ligament. Earlier we were using tackers. We have given up all that, and once we suture it, we get a good support there, and patient is quite comfortable with the whole thing. Procedure doesn't take too long, recovery is fast, and we advise them to do all their activities after a period of rest. So this is the gist, the whole repair. If needed, we would do a vaginal procedure also. Like if we find the cervix too long, we are not averse to going below and just amputating that part of the cervix. Several other laparoscopic options are also available, like lateral wall fixation. I don't know if you're aware, Dubisson introduced it many years ago, where he took a mesh, kept it horizontally, anchored it behind the uterus, took it laterally and fixed it. That has been modified now by Gunther Noe, where he takes the mesh and fixes it to the ligaments laterally. Today, he even uses plain native tissue laparoscopically, where we pick up the uterosacral ligaments, anchor it behind the uterus. There is also some fancy or crazy sutures, like the uterosacral suture sacrohistropexy, where they take one single big proline, take a long bite, fix behind the uterus, pull it up. A lot of things are there. These are all early methods. Some of them will get thrown out, but many of them will get back. But remember, in that young girl with an nulliparous prolapse, there is a definite role for lap repair. All your vaginal methods are definitely not going to work. There are several studies comparing vaginal versus lap. Laparoscopic approach to pelvic organ prolapse, is it the way to go or a blind alley? They concluded the traditional vaginal procedures are being gradually replaced by laparoscopic techniques. The benefits include reduced recurrence, reduced complication rates, and tending towards uterus sparing if desirable. Other studies also show that there is significantly less recurrence rate requiring reoperation, less catheterization, but increased operative time in the laparoscopic procedure. What everybody says is laparoscopic procedure is very expensive because it requires a complicated setup, a lot of payment of money in. But remember, when our patient needs help, we have to bend back to achieve better results. And the only way of doing that is by learning new techniques, improving the techniques, and make it work better. A very important part of the laparoscopic repair is the learning and the teaching. Remember, we are going to get more patients. And with more patients, we are going to have to do more procedures. It takes time to learn the laparoscopic procedure. You can learn the laparoscopic procedure, but even if you keep doing the vaginal procedure for many years, you will still be digging and finding out where that ligament is, because half the time you can't see it. So the ability to teach it is very, very limited, and that is the big issue which one has to think. Training in the vaginal procedure is very, very difficult, and we are really not going to have very many people doing that. So in short, everyone can learn, sorry, that went off, that shouldn't have gone. In short, everyone can learn the art as it is seen well. It does not depend on just fingering and feeling that as the ligament or feeling that as the tissue and trying to achieve what you want. So in conclusion, I'd just like to say, one, the vaginal approach, agreed, very good, very old, but it is relatively inefficient. I have to say that. The use of artificial supports is banned vaginally, so you cannot strengthen it in any way. Newer options, yes, you can see, you use the entire pelvic supports and offer long-term relief, and there is scope for even improving it a lot more. Training in laparoscopic technique is easily available and it is improving. So you're going to have a lot more methods to do it. So I think it's time all of you join together and say that we turn a new leaf from vaginal repair to laparoscopic repair. So we leave all of you thinking like a Rodin. Think, and do what you want. But there's a very simple method to solve Rodin's thinking, and all that was needed was this. Let's keep a simple support and solve the problem with a very simple method, not going to some other method which was historic, not in use, and this thing. So let's spread happiness with our endoscopy by doing good. Thank you very much.
Thank you so much, Dr. Kurian, sir. If you have any questions, we request you to please write down in a paper on this debate and pass it on to our volunteers so that we can discuss on it. Do we have any questions? There is a QR code as presented in the projector. Your feedback is crucial for improving our future events. We have transitioned to paperless feedback collection for convenience and sustainability. To receive your participation certificate, please take a moment to fill out the feedback form. Your input is highly valued. It is mandatory to fill out the form to get the participation certificate. Sir, anything on the debate? Yes, sir, please. One more point when the debate is coming up. Stage is all yours, Piley, sir.
Because it is a debate, I thought we cannot allow Kurian to walk away like that. Actually, what was his message? Laparoscopy is so glamorous. It has that sort of appeal for especially the youngsters. But behind all this, what we have to look at is science, the principles. As I told you, what we are doing is, suggesting is pelvic floor repair. And that pelvic floor is just in front of you. If you can repair and push it back, is it not better than go laparoscopically and do it? I do admit one thing. There is no glamour for the vaginal surgeon. I don't know how long it will survive also, because that's human nature. There's no money involved. And more than that, there is no promoter. As I used to say, the whole set of my instruments for vaginal surgery can be bought with the price of less than the cost of one accessory, one grasper. If a grasper costs, say, 40 to 50,000 rupees, the whole set will cost only less than that. So who benefits? There is no promoter for vaginal surgery. Just like what is happening in the obstetric field. No promoter for natural birth and vaginal delivery. Here also, cesarean and other things, there is a glamour involved. We don't have that. That problem is there. But are you youngsters going to go after glamour or science and say that a pelvic floor which is weak, which can be repaired effectively from below, should you not attempt that? The question is, do we have the ability to train the trainers like the laparoscopy surgeons have? Yes, we can improvise. We have them. People who are interested can come and see how we train. It is a little difficult, more difficult to train somebody in vaginal surgery than the laparoscopy surgery, because not only the absence of trainers, the teacher has to be bending down and showing and this and that, agreed. But the lesson meaning you should abandon it. You should persevere with it and take the advantage of it. I am glad there are people who still believe in that. And the American College itself has said, if there is no other contraindication for a hysterectomy, vaginal route is any day better than an abdominal or a laparoscopic or a robotic. Same way here, it's so much cheaper, easier to do. And regarding the mesh that Kurian said, I have no doubt that vaginal mesh is going to come back. I have been doing mesh surgery since late 90s, but documented from 2007. I have presented my paper, and the latest in the last 4 years, out of more than 100 cases, only one patient had problem with the mesh. But what has happened to mesh? Abandoned. This is the flow, like that. Some people went around promoting mesh caused problems, and the non-medical people dictated that mesh should be abandoned. In Scotland, what happened? In the whole of UK, what happened? Scottish Parliament dictated that nobody should use mesh, even TOT they cannot use. Is that the right thing to do? Vaginally that also happened. What happened in vaginal mesh use? The Australian paper, which suggested 18% of mesh erosion, was the one that put the balance against the vaginal mesh. And once somebody, it is the takers take everything. That is what happened. Nobody is there to prepare to try. And as Kurian rightly said, it is banned in some countries. In the US, they cannot make, but people can use self-cut mesh. They can use in the US, but UK is the worst. They cannot use. So that you are going by the flow without using your reason, and then ending into trouble. The soft polypropylene mesh, which I have been using since 2007, I had problems only when I deviate a little and use our Indian-made mesh along with that. Pure soft polypropylene mesh is so safe to use. If you put it in the right plane, it gives such good results. I have been doing both facial repair as well as mesh repair, and I can see my patients coming back. Even the best I have done, after 6 months when they come, you see that which I made very tight is sagging down further. Whereas if you use the mesh, the same advantage the laparoscopy surgeon is getting. You are using the mesh, so you get lasting results. But it is a misunderstanding if you say that there are no problems with the mesh by laparoscopy. Same problems. Erosion to the bladder, ureteric injury, erosion to the vagina, everything is there. But of course, the chance is less because you are not violating the integrity of the vagina in that, whereas vaginally when you do, we do have an incision and a suture line, and so the risk is a little higher. And of course, there is this issue about go by the general trend, the glamour of laparoscopy and all that is there. But that doesn't mean that vaginal surgery doesn't have any place. And of course, we have to think about the point I raised. Who are the ones who come with prolapse? Even though Kurian said, I am collecting all the women. Women are living longer. You all are going to live not only to 90s, more than 100. That is the time when your prolapse starts to appear. And will any anesthetist give you anesthesia at that time? With your pacemaker, this, that, everything. Whereas with a spinal, you can get this done. Or with even local, you can have a colpoclysis done. So that is why comorbidities is the limiting factor for surgery of prolapse of the elderly. And that becomes less of a problem for the vaginal surgeon. So I rest my case, vaginal route is the best for pelvic floor repair. Thank you.
Thank you so much, sir. Following this engaging debate, there is a question has come. The question is to whom?
One question to Kurian sir. What is the present evidence to say lap is superior?
This is a debate, not question answer session. Sorry.
Thank you, sir. Thank you so much.